Our next session will be chaired by Dr. Mohd Haroon R, Consultant Electrophysiologist at Apollo Hospital, Bangalore, Dr. H. Mallikarjun Swamy, Professor and Head of the Department of Medicine at KIMS, Hubli, and Dr. Mohd Ismail, Professor of Medicine at Kasturba Medical College, Bangalore. Kindly proceed to your seats. I invite the speaker for this session, Dr. B Patil, onto the dais to speak on ECG in chronic IHD, markers of low EF and high-risk patient. I request the chairpersons to introduce Dr. B Patil.
Good afternoon. I take the privilege to introduce Professor Patil, who is a famous professor of cardiology from St. John's. He is a founder fellow of Indian College of Cardiology, fellow of Cardiology Society of India. He established the department in Mysore Medical College, developed the Department of Cardiology at Bangalore Medical College, developed Department of St. John's Medical College. He is honored with the B.C. Roy Award by IMA, Ain Swarna Karnataka Rajyotsava Award by Government of Karnataka. He has been published many papers in journals, and is an active cardiologist who needs no introduction. I would like Professor Patil to go ahead with this topic, ECG in chronic IHD, markers of low EF and high-risk patients. Thank you.
Thank you. Good afternoon. So let us go on to the topic, ECG in chronic IHD, markers of the low ejection fraction. You all know that there is an increasing burden of IHD in our country. For one myocardial infarction, almost there are undetected 30 chronic IHD patients are still there, and stable angina occurs in 60% of the chronic IHD, and 2/3 of the IHD patients die of cardiac cause in ischemic cardiomyopathy. And this is one of the studies done in Abbottabad, Pakistan. Out of 183 chronic IHD, 60 had prior myocardial infarction with an EF of a 35 plus or minus 11%, and 123 without myocardial infarction, and there the EF was little higher side, 45 plus or minus 15%. And EF of less than 35% is always associated with a high risk, that is more than 3% annual mortality. So what are the causes for ECG changes in heart failure and ischemic heart disease? So it is the underlying structural heart disease itself can cause, or electrical instability can cause, or increased sympathetic activity with specific or non-specific ECG changes, may be due to the drugs or due to the underlying arrhythmias. And ECG changes depend on duration of the ischemic heart disease, the extent of the ischemic heart disease, and the topography, and also underlying abnormalities. So what are the ECG markers of a low ejection fraction and LV dysfunction? It is the most often the low voltage, a sum of the QRS complexes less than 12 millivolts is a marker of disease severity and adverse outcomes in systolic heart failure. In a retrospective study, out of 551 patients, 415 systolic heart failure patients, mostly of an ischemic heart disease, the low voltage was related to the NYHA class, and at 1 year follow-up had higher number of deaths and hospitalizations. And to rule out, before diagnosing low voltage, you should rule out a pericardial effusion, hypothyroidism, and amyloidosis, such conditions. And Q in precordial leads also suggests that there may be a low ejection fraction or an underlying LBBB, which I already heard in the previous lectures. And LVH in precordial leads and a low voltage in limb leads also may suggest that there is a low ejection fraction. And LBBB and LAD, that is left axis deviation, I think one question was there, and an atrial fibrillation together also suggests a low ejection fraction. And LBBB and RAD, right axis deviation, also suggests that there is an underlying more myocardial damage. And normal septal Q in mid-precordial leads, most often 1 ABL, and you can see in V5, V6 normally. And absence of a septal Q is a marker of poor prognosis and occurs in left bundle branch block and LAD occlusions also. The QRS duration is the next very important criteria. A graded increase in the QRS duration is correlated with mortality and sudden cardiac deaths. It is present in almost 20% of the heart failure patients, and in the MADIT-2 trial, almost 32% high-risk patients had this, with a QRS duration of more than 120 milliseconds. And QRS duration of more than 110 milliseconds and an HP interval of more than 55 milliseconds is a strong index of future arrhythmias, as published in Italian Heart Journal. And in the MUST trial, arrhythmic death and total mortality was related to the QRS duration and also intraventricular conduction defects. QRS duration and the BNP together and or even independently, they are independent predictors of systolic dysfunction. A QRS duration of more than 150 milliseconds in ICD recipients with a congestive heart failure is a simple, non-invasive prognostic index of increased mortality in that study. And decreased LV systolic function and the QRS duration are independent predictor of mortality. Now coming to the LVBB, lot you have heard in the last speaker, Dr. Makkar. 20 to 30% of congestive heart failure have an LVBB, which indicates diffuse myocardial disease and fibrosis and a marker of a poor prognosis. And in them, the 5-year mortality is around 35%. And LVBB and mid-LAD, and left axis deviation, I think Dr. Hanmantgad asked this question, indicates diffuse structural heart disease, an abnormal left axis. LVB can have a normal left axis, but an abnormal left axis indicates more structural heart disease. And regional wall motion abnormalities and decreased LV filling in LVBB also results in systolic dysfunction and also diastolic dysfunction. And LVBB and a right axis deviation is very rare, almost less than 1%, and this also indicates diffuse structural heart disease. ST-T wave changes, dynamic ST-T changes in a chronic IHD, again they are high risk. Following myocardial infarction, an ST depression of more than 2 anterolateral leads. Just now I think Dr. Lokonwala was also speaking. One AVL V5 V6 had higher cardiac deaths, severe congestive heart failure versus ECG changes in the other leads. And TIMI-7 and GUSTO-1 studies, almost more than 50% ST resolution correlated with a good TIMI flow and benign prognosis, unlike when there is no resolution at all. And in GUSTO-1 patients who had higher T waves had lower 30-day mortality, less heart failure or cardiogenic shock. Now coming to the left ventricular hypertrophy, it is again one of the predictor of arrhythmic events. It is assessed by either echocardiogram or by ECG criteria itself and predicts arrhythmias and mortality. Corneal product LVH criteria, there is an R in AVL plus S in V3 plus 6 millimeters in case of a woman multiplied by QRS duration more than 2440 milliseconds again indicates that there is a definite LVH. In 317 ischemic cardiomyopathy with a non-sustained NSVT undergoing ICD insertion for a primary prevention, over 3-year follow-up, corneal product LVH was an independent predictor of mortality in all the patients. Now coming to the fragmented QRS, conduction delay due to prior myocardial infarction or a myocardial scar can give rise to this fragmented QRS, and it has been confirmed by a regional perfusion abnormalities also. A QRS less than 120 milliseconds, an additional R wave is taken as a fragmented QRS, or a notching of nadir of S wave, or more than 1 R prime in 2 or more contiguous leads is also taken as a fragmented QRS in those who are having a more than 120 milliseconds QRS duration. It has a higher sensitivity, negative predictive value also versus just Q waves. Now coming to the Duke's TMT score, most often we do not do it, but this is one of the ways how we can risk stratify these patients. An exercise time in minutes, minus 5 times the ST deviation in millimeters, minus 4 into angina index. So what is the angina index? That treadmill is stopped due to angina has got a 2, and if angina occurs but still the test is continued is just 1, and if there is no angina it's 0. So more than +5 is low risk Duke's treadmill score, and 4-year survival is 99%, and annual mortality is 0.25%. Whereas less than -10 has a high risk Duke's treadmill score, and 4-year survival is 79%, and annual mortality is 5%. Frequency of VPCs and also slow heart rate recovery increases the risk of death. Heart rate variability is another criteria. It is independent predictor of overall mortality and sudden cardiac deaths. A beat-to-beat oscillation of relative risk intervals due to disturbed sympathovagal balance. Advantages are it is computer based, automated measurements can be done, and 2 algorithms are there, what is called as time domain and frequency domain measurements. And less than 50 milliseconds variation is independent predictor of overall mortality and sudden deaths. Disadvantages, it is not useful during exertion or during postural changes, and it has got low sensitivity and low positive predictive value. It is clinically useful but correlates with definitely LV function, and in congestive heart failure a low heart rate variability increases the cardiac deaths, and in one study less than 65 milliseconds variation had a significant risk of sudden cardiac deaths. Cardiac repolarization abnormalities in heart failure, diagnostically and prognostically they are useful for ventricular tachyarrhythmias. QTC, that is by the Bazet's formula, and QTCD duration, QT variability, QT dispersion, and micro T wave alternance. So all these are useful in predicting the future arrhythmias, and LV dilatation is related to lone VPC score, QT prolongation, and electrical instability and sudden cardiac deaths. Prolonged QT more than 450 milliseconds in males and more than 470 milliseconds in female is taken as a long QT, and you have heard a lot on long QT syndrome due to the drugs and electrolytes, all these things. So cardiac repolarization in heart failure, prolonged QTC and BNP together, BNP more than 400 picogram per ml are independent predictors of all-cause deaths, cardiac deaths, and sudden cardiac deaths, and pump failure deaths also. And QT variability is experimental and correlates with worsening functional class. QT dispersion is not used clinically and is a non-invasive marker of susceptibility to ventricular arrhythmias. Coming to the atrial depolarization and repolarization, P wave duration more than 20 milliseconds has susceptibility for atrial fibrillation in congestive heart failure. And prolonged signal averaged P wave duration predicts early death, development of atrial fibrillation, repeated hospitalization for decompensated heart failure. The latest study has come, what is called as Parapet study, it's still going on. These are the high risk ECG parameters. Atrial fibrillation, these are the odds ratio, what they have. Atrial fibrillation, non-sustained VT, fragmented QRS, persistent RV pacing, Q waves, LVH, LVBB, dynamic ST depression, elevated minimum heart rate, frequent VPCs, prolonged QRS duration more than 110 milliseconds, low heart rate variability, prolonged QTC, steep QT divided by RR slope, and wide spatial QRST angle. In Parapet study, which is still an ongoing study, 198 patients of ischemic cardiomyopathy with an EF less than 35%, with a 15 high risk parameters they have taken for arrhythmias were assessed, and 97% had at least one of these criteria, and only 4 out of 15 can be assessed in all the patients, and in 42% all 15 parameters were assessed. And prolonged QRS duration, fragmented QRS were frequent, followed by non-sustained VT and frequent VPCs. Just to conclude my talk, ECG can reflect future cardiac events, low voltage, presence of Q waves, LVBB, increased QRS duration, intraventricular conduction defects are markers of a LV dysfunction. Dynamic STT changes, left ventricular hypertrophy, fragmented QRS, high risk due to treadmill score, long QTC, QT dispersion, non-sustained VT or a frequent VPCs, low heart rate variability are high risk markers for increasing mortality and sudden cardiac deaths in chronic ischemia. Just to show some of the examples of our own ECGs, this is one of the patient, 49-year-old old interval MI with an ejection fraction 22%. You can see there is a sinus rhythm, biatrial enlargement, low voltage in limb leads and non-rising R up to V4 with an STT changes. Another patient, 35 EF being there with a triple vessel disease who has undergone a bypass surgery. So he had a sinus rhythm, he had a bifascicular block, left atrial enlargement, Q in 2-3 and AVF and V1 to V4 and occasional VPC he had. And this is another patient who has undergone a PTCA to LAD with an EF of just 28%. So there is a sinus rhythm, partial LBBB was there, left atrial enlargement with the STT changes and doubtful left ventricular hypertrophy. These are all high risk patients only. And another patient with a double vessel disease with an EF 31% has an LAE, left ventricular hypertrophy with strain and a non-rising R up to V4 with a Q in lead 3. So these are some of the examples of the ECGs who have already had a double or a triple vessel disease with an LV ejection fraction, and in some whatever I have talked, some of the criteria I think you can see in these ECGs. I think with this I end my talk. If any clarifications are there, I will.
Thank you, sir, for the excellent presentation of ECG features to diagnose LV dysfunction and high risk coronary artery disease. The message is very clear that we the physicians should not be casual in seeing ECG in diagnosing coronary artery disease. By simply looking at ST elevation or ST depression, we should spend more time with the ECG and look at all the various other features to diagnose LV dysfunction and high risk cases. This would be great. This would be of great benefit in those areas where echo facility is not available, because echo is an additional tool in diagnosing the severity and recognizing LV dysfunction and other things. Thank you very much, sir, once again for the lucid presentation. If there are any questions, you can raise the questions.
I told you just one or two criteria may not be able to interpret this. At least 4 or 5 out of this 15 whatever I have told you high risk criteria, then its specificity becomes more.
Not, is it necessary to keep in mind COPDs, associated emphysema, thick chest wall and other things?
Low voltage,
yes,
you have to keep all those things in mind.
In
associated comorbidities.
Comorbid condition to be. And coming to the first session, that acute coronary syndrome, as our colleague said, most of the times ECG may be normal, and even if the patient has chest pain, so straight away you cannot rely on the ECG. Troponin T and coronary angiogram is the only gold standard answer. That's what I feel.
Always please observe at least 12 hours.
12 hours.
We have burnt our fingers whenever we have sent the patient, including treadmill negative patients.
Negative, yes.
They have gone and
That's
died.
right, yes.
So never just take the chest pain as very simple. Always keep them at least 12 hours observation. Try to do serial ECGs. Try to do the enzymes 6 and 12 hours. Then only send them.
That's right. In the presence of a typical chest pain suggestive of an angina, we should keep in mind that ECG may be normal.
Yes.
So we cannot send the patient.
ECG is not a foolproof.
Yes.
You have
That's
to take
right.
the whole picture into consideration.
So it has some limitation, especially in acute coronary syndrome. ECG may be normal. That is the yes. Thank you.
Fully agree with you.
What he was talking in a setting of an acute MI, 2 out of the 3 have to be positive.
Yes.
It has been repeatedly told in all.
Classical WHO criteria.
Yes, because this
ischemic pain, typical pain, and enzyme rise, RNST elevation, which Dr. Yash told.
Yes.
Limb leads 1 millimeter, chest leads 2 millimeters.
Now,
out of the 3, 2 should be there.
Yeah, now the
and nowadays even the regional wall motion abnormality also has been added in the universal definition of the myocardial infarction.
Yeah, that's what exactly I wanted to tell. Pain, enzymes and typical presentation, 2 out of the 3, and if you add echo, that almost
adds
confirms.
to the value.
Thank you, sir. Thank you very much.
Thank you, sir. I request Dr. Mohd Haroon to hand over a token of our appreciation to Dr. B Patil. I request Dr. B Patil to hand over the certificates to the chairpersons.